Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, An Alabama Project, Reducing the Risk of SIDS and Other Sleep-Related Causes of Infant Death. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access that material. I'm Amy Stratton, Director of the State Perinatal Program at the Alabama Department of Public Health, and with me is Lorena Kaplan, Dr. Stacy Scott, and with Rosa Abram. Welcome, everyone. We have a lot of information to cover, so let's just get started now. So our topic today is safe infant sleep, reducing the risk of sudden infant death syndrome and other sleep-related causes of infant death. Safe sleep requires a consistent and repetitive message at the local, state, and national level to prevent sleep-related infant deaths. We're going to look at some of the terminology and the trends associated with sleep death. And the first one we're going to look at is one called Sudden Unexpected Infant Death, or SUDI. Sudden and unexpected death of an infant younger than 1 year of age. You have to have a full investigation of these deaths, and they are typically diagnosed as asphyxia, cardiac arrhythmia, or entrapment. Sudden unexpected infant death, when we're looking at those, we're looking at infection, ingestion, metabolic disease, SIDS, suffocation, trauma, which can be accidental or non-accidental, to eliminate these. Sudden unexplained death of a baby younger than 1 year of age doesn't have a known cause after a complete investigation. You have to have a complete autopsy, you look at an exam and do a complete exam of the death scene, and you review the clinical history when we're looking at sudden infant death syndrome, which is known as SIDS. Sudden infant death syndrome, in some cases, if the evidence is not clear or not enough information available, the death is considered to be undetermined cause. Several things that SIDS is not. SIDS is not preventable, but we can reduce the risk. It is not caused by suffocation, not caused by vomiting or choking. It is not caused by vaccines such as diphtheria, pertussis, and tetanus, or other immunizations. SIDS is not contagious. It is not the result of child abuse or neglect. And it is not the cause of every sudden infant death. When we're looking at other sleep-related causes of infant death, we have to look at accidental suffocation and strangulation in bed. These are deaths of infants that are caused by suffocation or asphyxia, which is a blockage of the infant's airway in a sleeping environment. Accidental suffocation and strangulation in bed is a cause of death code used to describe deaths that result from suffocation by co-sleeping, so that can be sleeping in the bed with another adult, child, or overlay. Strangulation, suffocation by soft bedding, or getting wedged or trapped. Let's look, before we begin the full discussion on infant safe sleep today, to put things in perspective. In 2009, there were 286 pediatric deaths nationwide from H1N1 flu. These pediatric deaths were considered to be an epidemic. Drastic public health measures were taken to reduce the spread, such as closing schools and daycares. 100 to 200 children die annually nationwide from the flu. In the U.S., there are standard recommendations for vaccinations. So when we're thinking about this, with the energy that goes into educating and preventing about flu-related deaths, What are your thoughts about the number of 109 sleep-related deaths that occurred in Alabama in 2014? So let's look at some of Alabama's statistics. In 2014, Alabama's infant mortality rate was 8.7 infant deaths per 1,000 live births. There were 109 sleep-related deaths in Alabama, and this accounted for 21% of the total infant mortality rate. When we break this down even further, we can look at it through maternal characteristics as well as infant characteristics. When looking at the maternal characteristics, we're looking at sleep-related infant deaths by the mom's age, and you can see at the bottom 15 to 19, 20 to 24, 25 to 34, and 35 to 50, showing that our greatest rates are in those first two categories, 15 to 19 and 20 to 24. When we look at the rate of sleep-related infant deaths by race, you can see in the yellow you've got the white per 100,000 live births and the black and other rate by 100,000 live births. And traditionally and typically, you see a disparity in the black and other population in ratio to the white population. The percent of sleep-related deaths by mom's education, typically you see that it is higher when those mothers have less than a high school education or a high school education or GED. And remember that these stats that we're showing are over a 3-year period of time, so that's the reason you have the 3 different columns. Those mothers that typically have some college education or a full college or postgraduate education have lower rates of sleep-related infant deaths. The percentage of sleep-related deaths by method of payment. So if you look at that first column, you can see that all of those babies that passed away were to mothers that had Medicaid as their primary source of payment. Then you have the private insurance, followed by your self-pay, and then a few of your other and unknown. The percentage of sleep-related deaths by the number of previous live births. This is one that kind of took us off guard when we comprised this data. It was amazing to see to us that those mothers that had 3 or more previous live births tended to have a higher rate of infants that died from sleep-related deaths. Percentage of sleep-related infant deaths by their birth intervals. So you can see that those that had a birth interval, their birth spacing was less than 18 to 24 months, less than 2 years, had the highest rate. And then those mothers that had a greater than 5-year span were second in line as having the highest rate of infant sleep-related deaths. So let's take a look at the infant characteristics now. The percent of sleep-related deaths by the sex, so you can see in the yellow is the male, and in the purple is the female. Typically, you have higher rates of infant death in the male sex than you do in the female sex. Percentage of sleep-related infant deaths by age. It's well documented that most infants that pass away from sleep-related infant deaths are in the first 1 to 3 months of age, and that's evident on this slide when you look at the 1 month to the 3 month age. Percentage of sleep-related infant deaths by birth weight. One of the things that people often assume is that infants that die from sleep-related death are those infants that are born low birth weight or preterm, and this shows just the opposite to be true. Most of the babies that have died in Alabama have been normal birth weight and full gestational age at delivery. Percentage of sleep-related infant deaths by gestational age, just to continue what we said in the previous slide, that you can see that those infants born greater than or equal to 37 weeks gestation had the lower rate. So now I'm going to turn this over to Lorena Kaplan from the Safe to Sleep campaign, Eunice Kennedy Shriver, National Institute of Child Health and Human Development. Thank you for being here, Lorena.
Thank you for having us. Well, we'll start by looking at our national trends for SIDS. We know that the number of U.S. sleep-related SIDS cases, including SIDS, is approximately 3,500 deaths per year, and that continues to be 3,500 too many. Since the Safe to Sleep campaign launched in 1994, and back then it was called Back to Sleep, the overall U.S. SIDS rate has declined by more than 60%, and the proportion of infants who are placed to sleep on their backs has increased by about 50% from 1993 to 2011. The incidence of deaths attributed to accidental suffocation, strangulation, overlay, and entrapment have quadrupled since 1984. So again, this is an issue that we need to address. And although the decline in SIDS rate was significant between 1994 to 1999, the rates have leveled out in recent years. Now, our sister agency, the Centers for Disease Control and Prevention, has developed national guidelines for infant death investigations, but they are not uniformly implemented on a national or local level. So folks who are involved in child death review efforts are probably very familiar with this challenge. Now, if we look at the U.S. SIDS-specific infant mortality rates from 1990 to 2013, we see that the risk factors for SIDS and other sleep-related causes of infant death go beyond back sleeping or the sleep position. The trend line in the middle, which is in green, represents the SIDS rate, which we see has declined over time. However, unknown causes of death or deaths attributed to accidental suffocation or strangulation in bed have increased, which have created a plateau in our progress. So one thing we can do to respond to this call to action, which is how we see that, is to teach parents about some of the things that they can do to reduce the risk for SIDS and SIDS. One of the most common risks is related to sleep position. Babies who are put to sleep on their tummies or in the prone position are at 5 times greater risk than those babies who are put to sleep on their backs, the supine position. Babies who are used to sleeping on their backs but who are then placed to sleep on their stomachs for whatever reason, even just once, are at 7 to 8 times greater risk of dying from SIDS. Now, we have heard from parents that there are some challenges to back sleeping. For example, parents are worried that their infant won't be as comfortable if he or she is placed to sleep on their backs. But this is an issue of sleep training. If babies don't know any other position, they'll be just as comfortable on their back as it would be on their tummy, which is riskier. They might be concerned about a flattened skull, and that's where we as educators can talk to parents about supervised tummy time. They may have gotten advice from others about sleep positions that are risky, or they may fear that their infant could choke if he or she sits up while lying on their back. But again, one of the things that we can do as safe infant advocates is to teach parents. So what we can do is to go over baby's anatomy. When an infant is placed to sleep on his or her back, the trachea or the windpipe lies on top of the esophagus. So if the baby spits up, the liquid will pool at the entrance to the esophagus, thereby making it easier for liquids to go right back down. But if baby is placed to sleep on his or her stomach, the liquid will pool at the entrance to the windpipe, which is now below the esophagus, thereby making it more likely the baby will choke. So co-sleeping is a term that you've probably heard about, but depending on the context, it can mean 2 different things, so let's review the definition. It is a sleep arrangement where the parent or another caregiver and an infant sleep in close proximity. So this has to do with how close the infant is to the caregiver. And they can be on the same surface or different surfaces so as to be able to see, hear, and or touch each other, which is a good thing. Co-sleeping arrangements can include bed sharing or room sharing. Now, room sharing and bed sharing are terms that we invite you to use because they are more specific. Room sharing, which is what the American Academy of Pediatrics recommends, is when the infant sleeps in the parent's room near the parent's bed, but on a separate sleep surface that was designed for an infant, such as a safety-approved crib, a bassinet, or a play yard. Now, room sharing is known to reduce the risk of SIDS and other sleep-related causes of infant death, which is why it is recommended. Bed sharing, on the other hand, is not recommended. This is where the infant sleeps on the same surface, such as a bed, a couch, or a chair with another person. And sleeping with a baby in an adult bed does increase the risk of suffocation and other sleep-related injuries, which is why it is not recommended. So why is bed sharing risky? Well, again, when we are sharing a sleep surface, there is an increased possibility of suffocation or even overlay. That is when the parent accidentally rolls on top of the infant. Adult beds typically have soft bedding on them. That means pillows, blankets, quilts, and bedspreads can pose a suffocation risk. Now, other SIDS risk factors include the racial or ethnic background of infants, as well as environmental exposure. And in particular, African Americans and American Indian Alaska Native infants experience a disproportionate rate of SIDS. African American babies in particular have a 2 times greater risk than white babies, and American Indian and Alaska Native babies have 3 to 4 times greater risk of dying from SIDS than do their white counterparts. These risks and dangers can be compounded when they are exposed to things like secondhand smoke, which alone increases the risk for SIDS by 2.5 times. So when we look at the data from 2005 to 2013 for U.S. rates of SIDS and other sleep-related causes of infant death by race, we do see that, in fact, African American babies and American Indian Alaska Native infants experience an elevated risk. The Caucasian babies are represented by, I think, the brown trend line in the middle, and we do see that Hispanic or Asian Pacific Islander babies have a lower risk than white babies. And while we're not 100% sure why these disparities are present, the data suggests that it's due to socioeconomic barriers, to cultural practices, and perhaps even some genetic or environmental risk factors that are more prevalent in one versus another group. Now let me give you a little bit of an overview about the Safe to Sleep campaign. The U.S. Department of Health and Human Services is the nation's primary agency responsible for protecting the health of all Americans and for providing basic human services. The National Institutes of Health, which conducts and translates research, is part of the HHS, along with 11 other entities. Some of our sister agencies include CDC and HRSA, the Health Resources and Services Administration. The Eunice Kennedy Shriver National Institute of Child Health and Human Development is part of NIH, and this is the institute that leads the Safe to Sleep campaign. Now, from 1994, when the Back to Sleep campaign launched, through 2011, the focus was on the back sleep message and also on teaching parents that one of the most effective things they could do to lower the risk of SIDS for their babies was to put them to sleep on their backs. And this recommendation was based on years and years of research, both national and international, which tied back sleeping to a lower risk for SIDS. Then in 2011, the American Academy of Pediatrics, after reviewing more recent data, expanded its recommendations to address risk factors in the infant sleep environment. And so in 2012, following the expanded recommendations from AAP, we too expanded the focus of our campaign to the infant's sleep environment, which is why our new name is now Safe to Sleep. And since 2012, we have been focusing on reducing the risk for SIDS and other sleep-related causes of infant death. But we don't do this work alone. We have campaign collaborators who are greatly valuable to our effort. And they include sister agencies like HRSA and CDC, the American Academy of Pediatrics, the American Congress of Obstetricians and Gynecologists, First Candle, the Association of SIDS and Infant Mortality Programs, and the Consumer Product Safety Commission. Now, the Safe to Sleep campaign messages continue to be guided by the American Academy of Pediatrics Task Force recommendations on safe infant sleep, and we contribute to the alignment of federal and national strategy to address safe infant sleep across the United States. And also, we make a concerted effort to partner with state champions like Amy and the Alabama Department of Public Health to tailor the programs for safe infant sleep. And to tell you more about that effort is my colleague, Dr. Stacy Scott.
I I'd like to take this opportunity to share with you some of the audience-specific resources that we have available that you can use in an effort to promote safe sleep practices throughout your state. First, beginning with the general outreach, we have statewide efforts, as Lorena spoke about, and some of the things that you will hear about shortly in the work that we're doing in Alabama. We have health care provider information, which includes nursing's continuing education. We have questions and answers for health care providers, which is sudden infant death syndrome and other sleep-related causes of infant death. We have African American communities. We have information with Spanish-speaking communities, American Indian and Alaska Natives, and fathers and grandparents. We have recently produced the Safe Infant Sleep for Grandparents and other caregiver videos that can be picked up, and you can see using our website listed below. Other materials that we have, printed materials, again, that you are able to order utilizing our webpage, which again keeps in the brochures, again, in various particular communities that you can reach out to, the DVDs, and other materials that are very helpful in your campaign. Now, how do we look and work together to reduce the risk of SUID deaths and SIDS deaths? Well, what we look at is that these are some steps that we recommend, again, in the ways that you can reduce the risk of SIDS and other sleep-related causes of infant death. Always place your baby on his or her back to sleep for naps and at night. Use a firm sleep surface such as a mattress in a safety-approved crib covered by a fitted sheet. Room share. Keep baby sleep areas or surfaces separate from your sleep area or your surface, but in the same room where you sleep. Keep soft objects, toys, cribs, bumper pads, and loose bedding out of your baby's sleep area. Room share. And again, this is another example of room sharing. The baby is in their own safe sleep area, and this is very important. We definitely promote breastfeeding. However, we do recommend that once you breastfeed, you make sure you return the baby back into a safe sleep area, as you see here in this picture. Women should get regular care during pregnancy. They should not smoke, drink alcohol, or use illegal drugs during pregnancy or even after the baby is born. Do not smoke during pregnancy, and do not allow smoking around your baby. Breastfeed your baby. Give your baby a dry pacifier that is not attached to a string for naps and at night. Do not let your baby get too hot during sleep. Follow your healthcare provider's guidance on your baby's vaccines and regular health checkups. Avoid products that claim to reduce the risk of SIDS and other sleep-related causes of infant death. Do not use home heart or breathing monitors. Give your baby plenty of tummy time when he or she is awake and when someone is watching. Again, this is an example of tummy time. Make sure that you have an adult there, because it's very easy for the baby to get tired and fall asleep on their stomach. The bottom line is that we are working to promote safe infant sleep environment. And again, this is in an effort to reduce sudden, unexpected infant death as well as SIDS. Just to give you a little background about some of the state initiatives that we've been working on, we are currently working in the state of Alabama. We have had an outreach program again about a year ago, which we know that Alabama was ranked fourth in the state, fourth actually in the country, for safe with sleep deaths. And so what we have done is that we've come in and done a 3-year project which provided $50,000 to communities to apply for mini grants. This funding from NICHD supports outreach and activities to address safe infant sleep and SIDS risk reduction. The eligibility for MiniGrant activities were safe infant sleep demonstrations, trainings and workshops to community members and healthcare providers, community awareness events, as well as community safety baby showers. And here are some examples of some activities that have gone on in an effort to promote safe sleep throughout the communities within Alabama. Again, with that, we're going to follow up, and I'm going to pass it over to Ms. Rosa for you to give you a little bit more detail about some of the things that has happened.
Thank you, Dr. Scott.
You're welcome.
So when conducting these outreach activities, there's two forms of encounters. The first one is the educational encounter, which will involve facilitating some sort of learning for your participants. So that being the case, we're going to have a formative effect on the participants that attend the event, and we've actually created a pre-test, post-test form. On the first side, you'll see the pre-test, and on the back side, you'll see the post-test. And every time you have an educational activity, basically you will have the participants in the room make sure they take this pre-test and post-test so that we can understand the knowledge that has been gained from the beginning to the end of the presentation. The second form of encounter is an awareness encounter, and here you're more trying to raise a level of consciousness around safe infant sleep practices, sharing information, much like those brochures we mentioned earlier, but there's no sort of evaluation that's really occurring. So for example, if you were to be at a health fair and you were to have a booth there, you would just be sharing a lot of the safe sleep materials but not necessarily evaluating the participants. In conducting these outreach efforts, we provided some digital Safe to Sleep campaign resources. One of the biggest pieces is this Flickr account that we've created, which is a repository of about 18 different safe infant sleep messages, safe infant sleep environments, I should say, much like the one you see here, and much like some of the ones that Dr. Scott mentioned earlier. And I'll go into forms and brochures a little bit later. But the big thing is involving project reporting. 50 is the golden number. So ideally what we would want is at least 50 educational encounters, which, remember again, for every educational encounter, participants will be filling out a pre- and post-test form. So we need 50 pre- and post-test forms. We'll have other requirements as well in terms of documentation, sign-in sheets, photo permission forms, but we're currently in the process of updating those forms for the next grant cycle. So for now, don't worry about those, but we'll go into lots of detail at our orientation meeting in December. Now, in terms of eligible mini-grant applicants, we have folks from the health department, community health centers, health coalitions, child care youth development agencies, hospitals, universities, and sororities and fraternities. And this year we actually have a new funding opportunity for first responders through our direct on-scene education program, better known as DOSE. And I'll let Amy be the DOSE expert, so in case anyone has any questions specific to that program, feel free to direct those to her. But I'll more talk about first responders as a funding applicant. So in that sense, first responders are firefighters and police officers, and they have this unique eligible opportunity to apply for a $2,000 mini grant. And if awarded the funds, they must complete at least one educational session, and that educational session must have at least 10 participants. And again, for educational sessions, that pre- and post-test is mandated, so 10 participants means 10 pre- and post-tests. And any remaining grant funds that they have, that can be applied towards providing any of the safe sleep environment components. For example, a portable play yard can be purchased. And you want to provide those to beneficiaries who otherwise would not have maybe the financial resources, for example, to provide the safe sleep environments on their own. If you are not a first responder, you won't be qualifying for this specific funding mechanism, but don't worry, you can still apply for the general mini grant application. Now, these are super important dates to keep in mind, and they are subject to change. But for now, the request for proposal is going to be released on September 28th. And once that's released and we get them back, we will notify you all about the mini grant awards on November 16th. And then we'll have that mini grant orientation meeting where we'll give a safe sleep training and talk about all the documents necessary on December 11th. And then we'll distribute the funds to all the mini grantees on January 8th. And then the funding cycle will commence then as well. Any incomplete applications will not be reviewed, so feel free to make sure, I should say, to complete applications thoroughly, and don't worry, we'll set up some sort of technical assistance during that time to make sure we help everyone out with applications if you have any questions. And again, each proposal is going to be considered on its own merit. Any additional information that you're going to have, again, we'll have the technical assistance if you have questions on the budget or any sort of description of activities. But once you are provided the funding, all the proposed projects must adhere to the budget guidelines. So if any changes are to be made during the grant cycle, you would have to provide an updated budget. But beyond that, if anyone has any questions or additional information, you can write to the AL safetosleep@iqsolutions.com. And I personally answer that, and we all answer that, so feel free to email any questions you may have up until that time and during that time.
I think for now we can open up the phone lines for
Any questions?
real-time questions.
Yep.
Are there any phone questions at this time? I don't have any email questions at this time either.
Well, I think that means we did an excellent job.
That's a great way to look at it.
No questions, so we ready to wrap it up?
Yeah.
Okay. Well, I want to start off by saying thank you guys, Lorena, Dr. Scott, Rosa, all of you guys for coming to Alabama once again and being with us here at Public Health. We are excited about a second-year opportunity to work with you guys. Did want to briefly mention that we are also trying to promote a SIDS Sunday outreach. And basically what that is about is that reaching out to churches in the different communities and having those pastors, those congregations, those members to really get that safe sleep message and to pass that on in the community. They will be providing the inserts to the bulletins at that church SIDS Sunday. They also provide a small token of their appreciation, which is typically a fan in the past. We also provide the pastor or priest or whoever in the church that they are involved. They are given speaking notes about safe sleep messages. So we're excited about that opportunity, excited about the partnership that we have with you guys, and really appreciate again you traveling to Alabama and partnering with us to improve our safe sleep.
Thank you for having us.
Thank you.
So much. Thank you for the opportunity.
And thanks to all of you for spending 30 minutes with us.
Yes.